My name is Dr. Yasser Osman, and in this presentation, I'm going to talk about the intubating stylet. In my opinion, the intubating stylet is one of the most important tools that the anesthetists use. It's life-saving. It has saved a lot of patients' life, and yet it is the underrated and seldomly talked about in our community. In this presentation, I'm going to talk about the different type of the stylets and their indication, the difference between them, how to use them, and the advances that happened in this field. The ordinary intubating stylet is a metal rod that is malleable enough to change its shape according to our needs. It is covered with a plastic covering just to decrease the traumatic effect of it. Comes in different sizes and diameters and lengths. It has a pediatric and adult uses. Can be used for different endotracheal tubes. The adult version is 14 French size, meaning that it has an outer diameter of 4.6 millimeter. It fits well into a 5.5 standard endotracheal tube and larger. But a 5 endotracheal tube can also fit with a little bit of difficulty. How to use the stylet? Well, first we introduce the stylet into the endotracheal tube and then we withdraw it a little bit so that its tip does not pass the level of Murphy's eye. Also, we bend the proximal end into 90 degrees, not to slip while we are using it. We yield the intubating stylet into two main shapes, either the McGill shape or the curved shape or the hook stick shape. This is according to the indication that we are using the stylet for. In this picture, figure A is the hook stick configuration and figure B is the McGill curve configuration. Usually we use the McGill configuration when the tube is malleable and we cannot guide it to the vocal cords, in spite that we have a good visualization of the vocal cords. But the hook stick, we can use it in a more difficult intubation situations. There is a debate when to use the stylet. Some centers say it is should be used routinely, and other centers do not use it as a routine practice because of the fear of the accidental trauma it might cause. But in some cases, like in armored or reinforced tube, a stylet is recommended because these kinds of tube are floppy and cannot be easily navigated to their destination. This picture shows the different view of the vocal cords. A and B is an easy intubation situation where we use the McGill curved configuration of the stylet just to guide and navigate the tube easily to the vocal cords, while C and D is a difficult situation in intubation. We use the hook stick configuration of the stylet. How we do this? By trying to hook it around the uvula or the anatomical site, as we can see, just guessing the correct position of the vocal cords. Please caution, Do not twist or bend the stylet, because this can cause kinking in the stylet and make it very difficult to remove the stylet from the endotracheal tube after intubation. Also, you should know that the stylet is a rigid object, so should never be advanced into the patient larynx or the trachea beyond the vocal cords, not to cause any trauma. The EMA D-Intubation stylet is a plastic stylet, has two plastic limbs. When we pull on one of them, the curve of the stylet changes, and so the curve of the endotracheal tube. In my opinion, it is only useful when we can see the vocal cords and we need just the stylet to navigate or to help us to navigate the endotracheal tube into its position. The Glidescope stylet is a stylet designed specially when we use the Glidescope in intubation. It has a easy to use handle, a rigid shaft, and a unique angle that can help us during intubation using a Glidescope. Rapid positioning intubation stylet. It's another form of stylet that has a mobile tip. We can adjust the angle of this tip by pulling on the handle. We can use this kind of stylet in difficult airway management, and also we can use it in video laryngoscopy. The patent pending G-Wand is another type of stylet that is a semi-rigid intubating stylet, has a flexible introducer tip to decrease the airway trauma, and has a direct source of oxygenation to keep the patient oxygenated during the intubation process. In my opinion, it does not add any benefit to the previous kinds of stylets. The gum elastic bougie, called also introducer, or the EBG for short. This device is moderately flexible and can be bent into shape from its straight form which is supplied from. The bougie are commonly about 15 French in diameter and 70 centimeter in length. The tip of the bougie is angulated at 30 degrees and should point anteriorly during intubation to facilitate the navigation of the device towards the anteriorly located larynx. The device is inserted into the airway first, then the endotracheal is rolled on it to the final position. Uses: it is typically for oral intubation when the view of the larynx is suboptimal, especially if it is anterior larynx. The bougie are also commonly used during endotracheal tube or tracheostomy exchange. Well, another indication, in my opinion, that is very useful to use the bougie in is a narrow mouth opening like this. In this patient, we can only introduce the blade of the laryngoscope and the endotracheal tube. If we do that, we will not going to be able to see the view correctly. So what we do is that we do introduce the bougie, so it is easy for us to introduce the endotracheal tube afterwards. Caution: please do not coil the bougie or change its shape, as this would make it very liable to cause trauma during usage, and this trauma can cause tension pneumothorax, which is a severe condition. I myself have seen a couple of my residents that caused such a trauma to patient when using a bad bougie. Airway exchange. catheter is used in the ICU mainly to exchange the endotracheal tube when needed. Frova intubating catheter is an invention by an Italian anesthesiologist called Frova in 1996. The catheter is available in two sizes, 8 and French and 14 French gauge. The length marking in centimeters that start from 10 centimeters from the tip. The tip of the catheter is bent and has two holes for oxygenation. The Frova catheter is also supplied with a stiffening cannula. The 14 French catheter can be used without the stiffening cannula, while the 8 French cannot. The stiffening cannula is straight, very rigid, and cannot be bent or adjusted in any way. The Frova catheter is somewhat similar to the gum elastic bougie, but the Frova catheter has an opening that can supply oxygen during intubation. It is also supplied with two RapiFit adapters, the Looker lock, and the standard 15mm breathing system connector. This is the two RapiFit connector. The first one is the standard 15mm tube connector for ambo bag use or anesthesia circuit, and the lower lock connector for the jet ventilation. Indication of the Frova is exactly like the indication of the bougie, with the added benefit, as we have said, that it allows oxygenation through the central lumen. Caution: the stylet of the Frova catheter is very rigid, and so serious damage can occur in the airway. So we have to withdraw the stylet as soon as the tip of the Frova catheter passes through the vocal cords. The stylet portion should never pass through the vocal cords and has to be visible during laryngoscopy at all times. Alternatively, we can use the Frova without the stiffening cannula. Personal opinion: you should at least be able to see the epiglottis during laryngoscopy in order to use the Frova or the gum elastic bougie effectively. The Aintree catheter. The Aintree intubating catheter was invented by Professor Peters in the United Kingdom. Is a blunt tipped 19 French radio opaque catheter with an internal diameter of 4.7 mm and an outer diameter of 6.5 mm. It has centimeter marking from 5 to 35 to the outside to help the placement. The catheter is just short enough to fit completely over a standard adult flexible fiber-optic bronchoscopy, leaving enough space to at the end for the bronchoscopy to flex and navigate. Approximately 2 centimeters from the distal opening, the Aintree intubating catheter has a small side hole on each side to ensure adequate airflow and reduce the risk of trauma when jet ventilation is used. The manufacturer recommends that we use a 7 mm or greater endotracheal tube, but 6.5 endotracheal tube can be used easily, while 6 is too small to be used with this kind of catheter. The Aintree catheter is supplied with the two RapiFit adapter, a lower lock and the standard 15 millimeter breathing system connector. What do we use this for? We use it for intubation primary through the laryngeal mask with fibro-optic guidance. Caution: it is not recommended to use the Aintree catheter to exchange the endotracheal tube. Rather, we use longer devices like the exchange catheter to do that. Caution: the jet ventilation through any catheter such as the Aintree or a Frova or the exchange catheter should be the last resort, as major morbidity and even deaths have been reported from accidental high pressure gas injection outside the tracheal lumen. The steerable tracheal intubation guide, or the new flexible tip bougie catheter. Flexible steerable tip makes it easier to navigate difficult airway. Use in conjugation with video laryngoscopy with optimal result. Slider is used between the thumb and the forefinger to move the tip anteriorly and posteriorly. And the blunt silicone tip reduces the risk of tracheal trauma. Bright phosphorus coating on the tip makes it highly visible. And it has also a pre-curved configuration. Graduation marks from 10 to 50 centimeter. It can use 7 millimeter in diameter or larger endotracheal tube. It's sterile and single use. Another kind of stylet is the universal stylet bougie. It has a unique design, incorporate two metal inserts with different and distinct property in between a more flexible middle section. The universal stylet bougie can be easily manipulated to a variety of angles when used as a stylet. Yet, it has the flexibility when used as a bougie, and it enhances the level of tracheal ring feedback. In addition, the hexagonal shape provides less contact with the inner surface of the tracheal tube, providing particularly easy insertion and removal of the tube. So it has certain advantages, which is a hybrid stylet between the bougie and the stylet. Improve insertion and removal due to its unique cross section. Improve storage and improve tracheal ring detection. The light wand is another kind of stylet that use a light in its tip. It was used previously, very common. What we do is that we put it in shape and we look for the light from the outside. When the light is in the proper position, then the tube is in the vocal cords or in its desired position. Now, it is not very commonly used. Now, the optical technology provides some kind of evolution in the stylet industry. The modified Levitan optic system or optic stylet is a stylet with pre-curved configuration that can be used during intubation. This is the original configuration of the Levitan, the top one, and another modification in the bottom. The Bonfils rigid endoscope is another one. The new CMAC video stylet which is the most recent one, is a stylet, straight, but the tip can be flexed and mobile by a handle at the proximal end. It adapts a tube easily and have a port for oxygenation. We can see here in this video how can we use it easily, and it only takes few seconds to intubate a difficult intubation case. Just by grabbing the handle, we can easily find the vocal cords by changing the angle of the tip of the stylet.
The vocal cords. Then I'm going to remove my hand and unlock, then intubate on the vision. I'm in. I'm going to remove the lock.
So, take home message, there is many types and forms of intubating stylet. You should be aware of and familiar with as many as possible. You should know the difference between them and what is the best choice in different situations. And remember, the best choice is always what you are familiar with.